All right, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum all. I would like to welcome everyone to the 10th annual spine update on behalf of the Saudi and on annual basis. And we continue to collaborate, work, and learn through our forums and case discussions. So the plan is we present anatomy talks with surgical applications. So this will be today from 4 to 8 with panel discussions. We have session moderators. Kindly, if you have any question, post it on the question and answer, and it's the job of the session moderators to get answers to you. We'll have case discussions, same time, and these 2 days. And so we'll get the first session. We should be starting at 4 o'clock, which is 8 minutes from now. Dr. Sami, do you want to say something?
Yeah, thank you, Dr. Amr. Thank you, Dr. Faisal, and the scientific committee for keeping Spine 20 or Spine update is, happening again. It's been like 10 years, also almost a decade since we started 2011. So we will be really enjoying the discussion and the talks today. I truly like the way that the program was structured in going through the anatomy first, and that will solve the issue of the being unable to do it physically as it used to be with the cadaver. We are missing the cadaver session this year. It's been nine years, consecutive 9 years, where we have a cadaveric session on the second day. But I would say with these, with the current situation, having the anatomy session will be a reasonable replacement for such wonderful experience that we used to have every year, the cadaveric sessions. So we will be truly enjoying the forum, the case discussions, and I looked at the cases that was submitted by the speakers, and it sounds to be we're going to have a very fruitful meeting. We're having international speaker, high caliber international speaker, who's also joining the meeting, plus our amazing Saudi speakers from all over the kingdom. So yes, we're excited, and we're definitely going to have an excellent meeting, and looking for it, and looking for a fruitful 2 days. Thank you, Amr.
Great, thank you, Dr. Sami. I would like also to extend our gratitude to everyone who worked on the program, scientific committee, admin assistants from Ms. Sumaya Bunayan, Kunuz Ritaj for changing from doing physical meetings into virtual meetings with great success so far, and wish them all the best. And we still have 5 minutes. I think we can invite any of the panelists if they want to share with us any note before we go live with the program. So maybe when just to housekeeping remarks. The first session will go from 4 o'clock to 5:40, and then we have a break until 6 p.m. We hopefully everyone could stick very much to time. We can have 2 minutes discussion after each talk, and then we'll move on. The discussion will be open between all the panelists. So feel free, please, to keep your questions, and we will discuss among us, and then we will also respond to all questions that come through.
Well, Amra, I guess even when Corona is over, I believe lots of meetings will continue virtual. And I see the virtual meetings and conferences are not bad, actually. Some of these meetings are, meant to be virtually. Like when we go back to the physical meeting, some of the meeting, I believe, will remain virtual ones as we get used to the way that we're handling virtual meetings. But not in spine update with the cadaver for sure.
Well, there is a lot of work going on to have hands-on training that you can do using your your phone with simple equipment that you can actually apply from home, using small animals or using small instruments. It's hard to put a pedicle screw into a chicken's vertebra, I guess, but I think we're gonna have to go sometime back to cadavers for sure.
But at least the hybrid one, like we still could have people in the forum joining us virtually, even in a physical meeting. So would you like to introduce the first speaker, because it's almost getting to 4?
Yes, for sure. So the first speaker is Dr. Abdulhadi Algahtani. He's a neurosurgeon working in National Guard Hospital, Jeddah. And Dr. Abdulhadi will be speaking on craniocervical junction.
Hello, everybody. Thanks for the invitation, and thanks for the introduction, Dr. Amr. And I'm going to present, this is quite complex and important topic in the craniovertebral junction anatomy. I know it's very complex and it's hard to accommodate such subject within 20 minutes, but I will try my best to finish in the planned time. So shall I start, or we can wait till exactly at the 4th?
Yeah, you can start sharing and just count down, almost 4.
So do you see my slides now?
Yes.
Okay. Okay, before I start, I have no disclosure or funds to receive, and this is my outlines, starting with the embryology, biomechanics, anatomy, which include the muscles, osseous, ligamentous, and some of the radiological assessment of this area. So the craniocervical junction, it is a complex area that, or a collective term, referred to the bones of the occipit, atlas, axius, with ligaments and membrane structure that ensure stability and mobility of this critical area or transition zone between the brain and the spinal cord. So in the other word, we can define it as osteoligamentous membranous complex from around the transition zone of the neural axis between the brain and the spinal cord. So this area it's almost all about the stability. So looking at this complex area, there is a complex interaction between the muscles, bone, and ligaments. And when we look to what is the behind the or maintaining the stability? It's all about these three factors. Number one, the geometry of the articular surface, particularly at the process of the occipit, like the condyles. And number two, the muscle. There is a numerous muscular structure which help to maintain the spinal alignment and helping in some way to maintain the stability. And number three, which is the most important here, the ligamentous or the ligamento membranous complex. As we know, this area or this location is lacked of the usual or the intervertebral disc. And adding more to this area is the horizontally aligned of the articular surface. All these factors making the ligamentous membrane structure a very important structure or element in maintaining the stability here. Another point, when we look to the atlanto-occipital joint and we try to define the mechanical properties here, is mainly or primarily determined by it is bony structure. As we see the condyles with the superior articular surface with the C1. On the other hand, the atlantoaxial joint is the mechanical properties determined primarily by the ligamentous structure. I will shed the light briefly about the embryology at just to complete the topic. We know at the 3rd week of gestation, there is 3 embryonal layer: mesoderm, ectoderm, and endoderm. And we will concentrate here about the mesoderm, and the mesoderm will continue to divide or develop into other 3 structures, mainly the paraaxial mesoderm. And the paraaxial mesoderm, it will continue to develop in craniocaudal manners, and it will form the somites. The somites in a human being, it is a primitive structure, and the human being, there is a 42 somites, and this somites, it will continue to develop and form and divide basically in two parts: the ventromedially, which will give the sclerotome, and this sclerotome will give us the bony and the ligaments and the membranous in this area. Specifically speaking, we are talking about the 7th sclerotome, the lower 4th of the occipit, and the upper 3 sclerotome from the cervical area. And so the upper 3 will give the basion, and the lower occipit will join the first cervical, and they formed the proatlas. And the proatlas, it is the primary sclerotome that's responsible or gonna provide most of the ligamento membrane complex in this area. Also, it will provide the precursor for the condyles of the occipit and some part of the atlas. Also, the first sclerotome will provide the precursor for the transverse and alar ligament. Again, the most important two is the proatlas and the first cervical sclerotome. Again, just quickly, the atlas, it has 3 ossification center, and one in the body, and 2 at the neural arch, and 2 also synchondroses at the body and the posterior. The posterior will fuse at the age of the 3 years. There is around 5% of the adults who gonna show failure of fusion. The axis, the same thing. There is a primary and secondary ossification center, and the secondary ossification center, which appear at the age of between 3 to 6 years, and it will fuse approximately at the age of 12. And here we can see an example of CT scan showed the secondary ossification center not appeared yet. So biomechanics, this is the most important part of my topic. So it's all about biomechanics. The first joint, the atlanto-occipital joint, is mainly responsible or providing this area with the flexion and extension. So Benjabi, he studied this area, and they found the flexion is around 27 degrees and the extension 25 degrees, and just minimal axial rotation around 8 degrees. The Steinman and his group came with almost the same results: flexion extension around 25 degrees, and to lesser extent, just 2.4 to 7 degrees. And this joint, the flexion is limited by the dens when going up to the foramen magnum, while the extension movement is held or limited by the tectorial membrane. and the axial rotation is limited by the contralateral ulnar ligament. So again, we are seeing complex interaction between the bony and ligaments and membranes. The second joint, the atlantoaxial joint, again, provide the primary movement here is the axial rotation, where it provides around 23 to 38 degrees. And however, Steinman's they found that there is some degrees of flexion extension that contribute to the cervical mobility. It's around 10 to 22 degrees, and there is very minimal lateral bending restriction around 6.7. Again, the extension movement here is limited by a tectorial membrane, and the lateral bending is limited by the contralateral ulnar ligament, and the flexion is limited by transverse ligament. Coming to the anatomy of the muscles, the posterior compartment of the neck, we can simply divide it into three layers: superficial, intermediate, deep. The superficial, basically from the trapezius muscles and the sternocleidomastoid muscles, which extend from the superior nuchal line, and also lateral, which is the superior occipital line. And just beneath the sternocleidomastoid, we can see the splenius capitis muscle that inserted on the mastoid process of the temporal bone, and also the rough surface of the occipital bone just below the lateral third of the superior occipital line. Below this intermediate, the semispinalis capitis muscle, it is a fleshy, broad muscles attached to the superior nuchal line, and is coming from the transverse process of the upper 6 or 7 thoracic vertebra with the lower cervical vertebra inserted at the level of the nuchal line here. Now we came to the deep muscle group, which the clinical significance here is making the borders of suboccipital triangles. Here the superior oblique, inferior oblique, and the rectus capitis posterior major muscle. This is formed the borders of suboccipital triangle, and the floor is formed mainly from the posterior arch of the C1 plus the atlanto-occipital membrane, and this triangle is covered by the fibrofatty connective tissue. And the content, as we know, it's the third segment of vertebral artery with the C1 nerve root plus some of the venous channels. This is the rectus capitis posterior minors attached to this inferior nuchal line and inserted or attached to the posterior tubercle at the posterior arch of the C1s, provide little or minimal helping in the extending the head. This another picture showed the superior and inferior nuchal line with the C1, C2. The C2 spinous process or tubercle provide a numerous substantial attachment to numerous group of muscles, which help again to maintain some degree the stability of the spine. Suboccipital triangle, we already discussed it, the borders and the triangles, and the clinical significance that the location of the vertebral artery where it crosses the superior surface of the C1 in the atlas arteriosus. Here, just briefly about the anatomy of the occipit. This is the broad central thick bone, which is the clivus, which formed by from the synchondrosis of the basiosphenoid with the occipit. And there is the clivus can be divided into 3 parts. The one at the level of just above the level of the sella torsica, and the middle level at the level of sella torsica, and below it the third level. Also, the clivus can be it is separated from the petrous apex of the temporal bone by the petroclival fissure, and the petroclival fissure extends anteriorly from foramen lacerum, going backward and laterally to the jugular foramen. Also, the clivus, has a pharyngeal tubercle, which provide an important anatomical landmark for anterior approach, especially for endoscopic approaches. And also here, the attachment of the muscles which is the capitis and the longus colli. And here the condyles is direct. It's found in the anterior half of the foramen magnum and is directed downward, and laterally it is an ovoid convex shaped, articulate with the superior articular facet of the C1. Behind it there is a condylar fossa which accommodate the condylar canal and the jugular process. This is the external occipital protuberance with the lateral of the superior nuchal line, inferior nuchal line. This is the occipital crest descending downward to the foramen magnum. This is the styloid process which directed downward and forward and medial, and this is the mastoid process which also an important anatomical landmark, provide insertion for a lot of muscles. This is the axis. The axis, it's the first cervical vertebra, as we know, and this lack of body, there is no body here, and also lack of the spinous process, and it has basically two arches, anterior and posterior, with the two lateral process, and then the two arches join the lateral process laterally. And this, at the joining the lateral muscle, this is considered the weakest bone. That's why it's common area for fractures and result in Jefferson fracture. Laterally, there is the transverse process and very wide in compared to the subaxial spine. And this is the exit of the vertebral artery where it turns sharply medially across the superior surface of the vertebra of the posterior arch and the ductus arteriosus. There is anterior tubercle, which provide an attachment for the ligaments. And also this is the fovea dentis, where it's attached or closely adherent to the dens or the dentoid process. And here, just medial and lateral to the fovea dentis, there is a tubercle, and that's the attachment of the transverse ligaments. Also, the transverse process provide an insertion and attachment of number of muscles. Here, there is a membrane which attached to the occipital axial membrane, the same thing anteriorly. So the C1 is, the lateral process is directed upward and backward and forms a cup with the corresponding condyle, occipital condyle. And we discussed already the weakest points and the tubercle. This is an anatomy showed that the posterior arch of C1, C2, the lateral mass of the C1, and the C2 nerve roots with the curving and the axis of the vertebral artery before it pierces the atlanto-occipital membrane, and in order to enter the posterior fossa and become as a V4 or 4 segments. The axis is a typical spine vertebra, and it's the dens which acting inserted within the C1, and this is the area where it's attached of the transverse ligament, and the transverse ligament will keep the dens just secured into its position and separated from the posterior compartment in order to maintain the rotational movement. Now we came to the anatomy of the ligaments. The most important one is the cruciate ligament. We know the cruciate ligament has two segments, horizontal and vertical. Vertical, it has no significant role in terms of stability, and very thin vertical layers that attach from the basement to the dorsum of the axis, while the horizontal, it is the strongest, thickest, and the most important ligaments in this area. The horizontal is come from the posterior lateral of the dens and is attached medially to the axis in the tubercle. As we discussed, it's the thickest and strongest, and the thickness and the height is range from 6 to 7 millimeter, and it's considered a major player in terms of the craniocervical stability, in contrast to the vertical segment, which has no role in stability. Tubbs and his group, they studied the tubercle and provide an important anatomical information about the dimension of this tubercle where the transverse ligament attached. They said the width is around 5 and the height 6 millimeter, and the intertubercle distance is around 15 millimeter. And we know the function is to ensure axial rotation and restraining or limiting flexion at the level of the C1, C2 joint. The second important ligament is the alar ligament. Alar is coming from the Latin root, which means wing. Okay, and this ligament it's narrow at its origin, as it's originated from the dens and going upward and superior to attach to the medial surface of the condyles. They measured the angle between the two leaflets, and they found the mean is around 150 degrees. It has a main role in limiting axial rotation and side bending. It's considered a very strong ligament, and it's the second ligament after transverse ligament, which play a major role in terms of stability. This is an axis diagram which showed you how the alar ligament limits the axial rotation and the lateral bending, which is whenever we rotate, whenever the C1 rotate over the C2, the contralateral ligament will be strengthened, taut, and that will limit the rotation. This is an example. CT and MRI showed an injury of the alar ligament. You can appreciate here on the right side there is an increase of the distance or width of the occipital, atlanto-occipital and atlanto-axial joint, where in the left side is almost normal. In the MRI we see again the hypersignal chain, which signify a ligamentous injury. Tectorial membrane and posterior longitudinal ligament. When we talk about tectorial membrane, there is a discrepancy about this membrane. There is lack of sufficient data or evidence about this membrane. So some authors or scientists, they said it is an important membrane, play a major role in terms of stability and limited extension, while others, they say this has a limited role and is only limiting the flexion rather than extension. However, this is considered a very large but thin structure, and it's extend from the basion downward to the axis, and it will continue as posterior longitudinal ligament. It can be histological divided into 3 structures, the 2 to 3 layers. The layer number 1 is the largest and can attach up to the level of the internal auditory canal, and it blend with the dura there. The second layer is the thickest, and this is relatively it's hard and the strongest layer between these 3. And the third layer is very loose and with the free edge. Again, with the advance in the cadaveric dissection and research, they found the lateral part of which was thought that the lateral part of the tectorial membrane, in fact, it turns a different or distinct ligaments called the accessory atlanto-axial ligaments, okay? And that ligament extends from the axis to the atlas and provides some sort of stability. Tubbs and colleagues, they measured the tectorial membrane. They found its range, the width, the length is around 5 to 7 centimeters, with the width 2 to 3 centimeters, and the depth or the thickness range from 0.5 to 1 millimeter. Again, this is, I show you that there is multiple discrepancy about the tectorial membrane. So, for example, here then they conclude that the tectorial membrane helping restricting the flexion rather than extension. However, the other scientists, Odan and Van Gerdel and colleagues, they say this only play a role in restricting flexion rather than extension. Again, the posterior atlanto-occipital membrane, it is a thin membrane which has no role in terms of stability, and it's extend from the base into the posterior arch of the C1 and pierced by the vertebral artery before it becomes as a V4. Anterior longitudinal ligament.
Dr. Abdulhadi, may I interrupt? We are coming to an end. Can you summarize in less than a minute, because we have to move on? We have a long...
Sure. So basically, there is apart from the most important ligament, the cruciate and the other ligament, there is a different accessory ligaments like lateral occipital and barcal ligaments and occipital ligaments and the other membranes. And all these ligaments interact with each other in order to maintain stability. And we need to know these ligaments by heart in order for better assessment and choose the right modality of treatment. There is a various mechanism for injury, so each mechanism can cause injury to distinct or group of ligaments. And nuchal ligaments, it's like other ligaments. However, some studies mention that it's rich with the proprioceptive fibers that can give a role in spinal alignment. The blood supply is mainly coming from the vertebral artery by giving anterior and posterior ascending, and some branches from the internal carotid and external carotid artery by ascending pharyngeal and occipital arteries. These some lines which could help us in assess this complex area, and a lot of lines and measurements in both X-ray, CT, and even MRI scan.
Thank you.
Will conclude.